Welcome to the series. Let's jump right in. This explainer is based on the literature review Ménière's Disease, a vestibular physician's deep review of endolymphatic hydrops, diagnosis, and management. It's published by Australian Dizziness Clinics, and you can find the whole thing over at australiandizzinessclinics.com. Okay, so endolymphatic hydrops. We all know it as the defining histopathological feature of Ménière's disease, right? But the translation from that microscopic hydrops to a full-blown clinical attack? Well, that involves some complex additional mechanisms, and the upstream etiology is just irreducibly multifactorial. Today, we're going to unpack the ion physiology, the two major attack translation models, and those 6 key etiological cofactor categories. Here's our roadmap for today. We're going to start with the hydro paradox, then look at ion physiology and regulation, break down the 2 attack translation models, explore the 6 etiological cofactors, and finally, bring it all together with the multifactorial synthesis.
All right, let's start with Section 1, the hydrops paradox, or why hydrops is necessary but not sufficient.
So ever since Hallpike and Cairns first demonstrated it way back in 1938, we've basically accepted that the abnormal expansion of the endolymphatic compartment is the canonical pathological substrate of Ménière's. But here's the absolute paradox. Hydrops alone does not strictly equate to clinical Ménière's disease. I mean, asymptomatic hydrops exists in temporal bones from people with literally zero history of the disease. And conversely, some patients with severe classic symptoms show only mild hydrops at autopsy. It's fascinating, right? This brilliant dissociation really proves that hydrops is necessary, sure, but it is not sufficient. And that realization acts as the absolute inciting incident for our modern multifactorial framework.
Moving on to Section 2, let's zoom in on ion physiology and regulation at the micro level. To truly understand how this system fails, we've got to look closely at the membranous labyrinth. If you check out the normal anatomy here on the one side and then compare it to the Ménière's ear, you can clearly see how completely distorted it gets. The scala media is just markedly enlarged, and look at Reissner's membrane dangerously bulging right up into the scala vestibuli. It's a striking physical manifestation of that progressive fluid pressure building up. So why exactly does this fluid build up in the first place? Well, the endolymph filling the space is a highly specific, potassium-rich fluid that bathes the apical surfaces of the hair cells. And normally, its volume and ionic composition are incredibly tightly regulated by 3 exact structures: the stria vascularis, the dark cells of the vestibular labyrinth, and the endolymphatic sac. In Ménière's disease, this precise homeostasis basically crashes. These structures collectively fail to maintain the volume, which leads directly to that dangerous progressive distension we just saw. Now, as clinicians, translating all this complex histopathology to our patients is absolutely vital. In this overfilled balloon analogy, it's a real game changer. Think about it. When the drainage valve is blocked, fluid and pressure just build and build to a critical tipping point. Explaining it this way empowers your patients to understand exactly why they feel that intense, horrible oral fullness right before an attack, and you don't even have to overwhelm them with the mechanics of ion fluxes. All right, let's hit Section 3, the 2 attack translation models, focusing on the actual mechanism of the attacks. Okay, so we know the balloon is overfilled, but how does that translate into those acute, violent clinical attacks? For that, we rely on 2 complementary models. First, you've got Schuknecht's classic membrane-rupture hypothesis. This suggests that the highly distended membranous labyrinth eventually just tears, typically at Reissner's membrane or the saccular wall. This suddenly dumps all that potassium-rich endolymph straight into the sodium-rich perilymphatic space. The result? Acute potassium intoxication of the 8th cranial nerve. It is total biochemical chaos, triggering the violent vertigo and the hearing drop, which really only resolve hours later once that membrane finally heals. On the flip side, we have the drainage failure model. This points upstream, framing the endolymphatic sac as a faulty pressure relief organ. So, structural issues like sac hypoplasia or peri-sac fibrosis mean the ear just cannot resorb fluid, which is what drives the pressure up initially. And here's the key takeaway. These models are not mutually exclusive. In fact, both human temporal bone studies and animal models show us that these mechanisms very likely coexist to generate the clinical attack. Let's pull back to the macro level now in Section 4, the 6 etiological cofactors. So, having established the local mechanism of failure, we have to ask the big question: why do some people's drainage systems fail while others function perfectly for a lifetime?
Well, these 6 specific etiological cofactor categories comprehensively outline those upstream vulnerabilities, and they elegantly explain the immense, sometimes frustrating heterogeneity we see in Ménière's presentations. It could be anatomical, like a congenitally narrow vestibular aqueduct. It could be genetic, considering we see familial clustering in about 5 to 15% of cases, linked to specific genes like COCH or PRKCB. We also see really strong autoimmune associations, viral DNA frequently detected right in the sac tissue, vascular and migrainous overlaps, and even some weaker associations like trauma or hypothyroidism.
Now let's zero in on the autoimmune and migrainous factors for a second, because we see these all the time in clinical practice, right? For instance, think about a vasospastic insult from a migraine. That event could easily unmask asymptomatic hydrops in an already vulnerable inner ear. And for us as the treating physicians, that creates a highly confusing clinical picture, a phenotype that is almost completely indistinguishable between vestibular migraine and early Ménière's. Similarly, circulating anti-inner ear antibodies or an elevated systemic autoimmune response can aggressively attack the stria vascularis. This is exactly why identifying the underlying, specific cofactor for each patient is absolutely crucial for targeted, effective management.
This brings us to our final section, the multifactorial synthesis, where we put it all together.
Tying all of this structural and etiological data together leads us to a massive, modern paradigm shift. And it's perfectly captured by this single concept. Ménière's is a heterogeneous, lifelong syndrome rather than a single biochemical lesion. Read that again. It proves that clinical expression absolutely requires an unstable fluid system dynamically interacting with distinct, individualized triggers. It acts as a final common pathway. And honestly, this explains exactly why a standard, one-size-fits-all treatment approach so frequently fails us in the clinic.
So, considering all this underlying biological and anatomical complexity, it leaves us with a pretty provocative question. Does the classic symptom tetrad and the Baronese Society criteria actually capture this complex, multifactorial reality in a living patient? Well, in our next explainer, we're going to dive right into the clinical features and those 2015 Baronese Society criteria. We'll break down the classical tetrad in detail, examine the precise duration window that really drives specificity, and outline the exact investigation strategy that supports your diagnosis and rigorously excludes mimics. You definitely won't want to miss that.
Before we wrap up, for additional resources, including the full literature review, the clinical cheat sheet, the audio overviews, and the rest of this explainer series, make sure to visit AustralianDizzinessClinics.com. And please, hit subscribe and leave a rating to support this series. Thanks for joining me.